Welcome to the last lab demonstration. We are as excited as you. So that's the great thing, yes. All right, I've got a 10 by 12 lengthwise in the bucky. We're at 40 inches. Patient prep is the same as it has been for all the other head work. Everything off from the neck up. Necklaces, chains, earrings, other piercings on the face and tongue and wherever you might else pierce. And glasses off, removable plates out of the mouth, any hair stuff off, no caps, all that kind of stuff. Okay. And yes, we are doing SMV, and then we'll do lateral facial and lateral nasal. So we're going to start with the SMV, Submentovertex or vertex. Okay. So that is the direction of our central ray. We're going from underneath the chin out the top of the head. Okay. Positioning for this, ideally you would like the IOML to be parallel to your image receptor. And then you want your central ray perpendicular to the IOML. If you can't get the IOML parallel, you still must keep your central ray perpendicular to it though. And so I'm going to show you one. She can get her head back all the way. I'm going to show you one with the head all the way back, and then we'll show one if somebody can't get their IOML parallel, what to do then. Okay. Collimation-wise, it's going to vary from person to person. You can probably start somewhere at about 7 by 7, and you might have to make some alterations from there. But we'll talk about what needs to be included in your light field as I get it positioned. Now, in order for her to get her head all the way back, the vertex should be touching the image receptor. So if you put the patient right up against the board, they'll never get their head back. Okay, so you're going to have to move the chair out away from the wall a little bit and then let your patient lean in so that the vertex touches the board. Okay, that's about as far as I can go. This is how limber I am. This is it. And only because the walls hold me up, I'm not falling down. So that's what we want to do. So you'll never use a rolling chair, but you want to scoot your patient away from the board a little bit to get started. And these can be done standing if you really wanted to. And sometimes that can be easier, sometimes it's not. But you know, we usually sit our patient because that's more comfortable for them. But keep in mind, if you have a really hard time, sometimes standing up can make things easier for a patient. Okay, so I'm going to go ahead and kind of line her up so that she's centered mid-sagittal plane to the middle of the board. Okay. And you want to give neck support as your patient's head goes back, and definitely when their head comes back up, give some neck support because it's a big pull to be able to do that. Okay, so I'm going to let her lean her head back. She does a really good job here. So I'm going to center mid-sagittal plane. Then I want my crosshairs are going to be underneath the chin, but these that come this way, you want this to come off the highest point of the cheekbones. Okay, I'm going to bring that up so that it comes off the cheekbone. Make sure the head's not rotated. Okay, and this is pretty good collimation. You can see I've got light on both sides of the head. What I'm looking for too is to make sure that I have nose shadow. And I'm sorry I have to mess up your hair to show that. But I want to see nose shadow. See how I have nice nose shadow? And then actually lined up here. And because it's a bilateral exam, it's best to do right and left markers. You don't have to, but it's the best thing to do. We would like to see you do that in here. And your collimation is open, like I said, from side to side, plus top to bottom. You want to be sure you're including the EAM, because the attachment for the zygoma comes almost to the ear. So it comes right up here. So if you open your collimation to the EAM, you won't clip the attachment for the zygoma. Okay. Y'all good with that? Mm-hmm. Now I'm going to give support, and she sits up. Okay? So ideally, and hopefully all of y'all can do that, but a lot of people cannot get their head all the way back. So if she can't get her head back, she's going to scoot the chair back a bit, and let's say that's all the farther she can go. So what I'm going to do is still make sure the head is straight and centered. And I'm going to have to come down. I'm going to have to put some angle on my tube. Now, I want to see that the central ray is perpendicular to the IOML. But visually for me, you do this whatever works for you, I kind of look at the IOML as a plane with this hand. Then I look at the surface of the tube as a plane, and I get them parallel to each other. Does that make sense? Because then the central ray will be perpendicular. I just see that better, personally. So I'm going to put some angle on, bring it down. And if you're not sure, like I said, you can kind of eyesight that. And plus, then what you're going to do also is look and say, do I have no shadow? And if you don't have no shadow, then probably you have not angled enough. Okay? See the difference that makes? How now I have no shadow and I didn't have it before. And I can look at that and I can see that I'm pretty parallel there. Okay? And lean forward just a little bit. Oh, I'm sorry. Just going to line that up so that we can see the whole thing together. But now, same thing, my collimation is still good, but I have good nose shadow. Be careful though, be sure you're looking at nose shadow and not chin shadow, because if they get their head way back, if they got their head back and then you angle, you'll get chin shadow, which is very smooth and rounded, and you can tell it does not look the same as nose shadow. But that can happen if you really have IOML parallel already, and then you angle.
Point it out on the board.
What?
Like the nose shadow up top between the markers.
Okay.
Yeah, okay.
That's nose shadow.
I was making sure. Okay.
Yeah, and what you'll notice is nose shadow will be more triangular, and then when you see chin shadow, it really rounds more.
Okay.
And so you can tell what that looks like. Okay, so that's SMV. And then you do the same things about making sure everything's included. Okay, you can relax. Okay, so that's to show zygoma. So you get like those jug handles happening. Next, we're going to do lateral facial bones. Okay, so coming back to perpendicular. I'm going to leave that 7 by 7 collimation and then determine if I can collimate down or not. Now, all laterals are positioned the same. The only thing that's changing is our centering point. And our collimation will change depending upon what we have to include.
So lengthwise,
yeah, you don't have to change the orientation of this. No, because we've collimated down, so keeping it lengthwise will be fine. The only one that really makes a difference on is the skull, because the skull has to go crosswise or you'll never get it front to back. The others, because you collimated down, as long as you're smaller than the 10 inches, then it really won't matter which way you put it in there. All right, so I'm going to oblique her. Be sure you turn the apron a little bit. And I didn't clean that board. I thought you did. No, I was checking it, but I didn't clean the board. That's not bad. Well, actually, I remembered before I put her face up against it. I don't think I count off for that. You did it before you put your face up. But what we're going to do is the position will be the same, so that IPL is perpendicular, mid-sagittal plane parallel, and then IOML parallel. Okay. Centering for this, I'm going to center her zygoma to the image receptor, so like the high point of her cheek. And then sometimes you have to center a little bit lower because you have to include the mandible here. All right, and we didn't want the mandible before, we didn't care about the face before, but now we care about the face. So we're going to start by centering at the zygoma. We may have to open our collimation a little bit top to bottom because you want to get all the orbit. So you want to be about halfway into the forehead and make sure you're below the mandible. So you can open it up a little bit, and you may want to center just a little bit lower, and it'll be okay. All right.
You said MSP was parallel. What else was parallel?
IOML.
Okay.
So she turns her head. We get IPL perpendicular, MSP parallel. I'm going to bring you forward just a little bit. I'm going to bring this down. Oops, I'm sorry. Probably not like I did. Sorry. So when I come here to zygoma, which is where I want to be, I'm a little close here. So I'm going to open this up to about 8. Now I feel better about getting the chin. And I'm good about getting the orbit here. And I want to make sure I'm far enough back that I get all the EAM in there, because again, I want to make sure I have attachment for the zygoma. Okay, so that is a 7-inch wide and an 8-inch tall collimation right there. But it'll vary from person to person. If somebody's got, a shorter head, then you may not have to open it at all. But I just want to feel good about getting the mandible, and good about having the orbits.
And you said you need to include the EAM too?
Yes, go as far back as the EAM because you want to make sure you get the attachment for the zygoma. Again. That way you got all the, I mean, you really got to make sure you got all the face. So you want to open up to get the face. All right, everybody good with that?
You just use the left marker?
Yes. Mine's still on me for that because I did not put the left marker. I'll give you that one, I didn't mark it. Yes, left marker. Okay. Now the last one we're going to do is lateral nasal. And when you do lateral nasal, you would actually do that bilateral. You would do both of them because they are separate bones, and so you would do right and left lateral nasal. Lateral nasal bones are generally, because they're so small, are done tabletop, which means that if you are somewhere where you're using cassettes, the patient would hold the cassette outside of this, okay? You would not want to use a grid. If you're somewhere that does not use separate cassettes, or you don't have that capability, which you could probably, I think everybody still has some cassettes, so you could do that. But if you don't have that capability, then you would want to make sure you remove the grid and shoot it with a hand technique. We're going to do no grid hand technique because this is very small, okay? The nasal bone is very small. And you'll notice on the skull and on the facial bone and on the sinuses that when we do those laterals, you never see the nose. And you don't see the nasal bone because you burned them out, because the exposure factors you have to use in order to penetrate everything else requires you to use the grid. So that's why you want to be no grid when you shoot the nasal bones. All right. And in centering, we're going to center just below the nasion. Okay, just below the nasion, and we're going to have our collimation to include halfway up the forehead to the part in the lips. So from halfway up the forehead to the part in the lips. And then from front to back, we must include all of the soft tissue of the nose and past the outer canthus. So all the soft tissue of the nose and past the outer canthus. That way you know you've got the attachment for the nasal bone, because it does sit back posteriorly a little bit, you know, towards the orbit. So you want to make sure you don't clip any of that. It's important that you get all the soft tissue of the nose because they could have soft tissue damage, and this is part of why you would want to do it without a grid, because you can evaluate soft tissue damage as well. Okay, so positioning is the same. IPL perpendicular, MSP parallel, IOML parallel. Exactly same positioning.
IPL perpendicular, what?
MSP parallel and IOML parallel. So I'm going to center just below the nasion. I'll make this down some. So I'm up the forehead, I'm to the part in the lips, I have all the soft tissue of the nose, and I'm back well past the outer canthus. And I could still slide her back a little bit, but watch your crosshairs because you want them to be on the nose. You don't want them to be all anterior to that. You know what I'm saying? So you're going to have to leave your collimation open a little bit to be able to do that. Otherwise, you're centered to the board and not to your patient at all.
You guys include too much, then not enough.
Correct. So we're back here far enough that I know we're going to get this attachment here to here, back and forth. We have to open up to the part in the lips because you must include anterior nasal spine. That must be included on your lateral nasal bone. Not that I've ever seen anybody with a broken anterior nasal spine. No, but that's the rule. The rule of which we did not write. Okay, so those are the three you do, but realize that this one you would do right and left. We're only going to make you do one, but you would do right and left. And that's it. Okay, so you'll check off next Wednesday. There'll be no anatomy, there'll be no image, it'll be just a check off. We do have all the Tuesday people filtering in on Mondays and Wednesday, on Monday and Wednesday. So y'all will have first go at checking off, but as soon as you're done, then people from Tuesday are going to check off behind you. So we'll just get everybody in and out, because it should not take very long.